Okay, great. Good morning, everyone. I'm so pleased that you're all here to join us for another terrific Senior Law Day collaborative program this morning. Today, we have two terrific presenters, the dynamic duo of healthcare, if you may, Megan Shergill and Keith Singh. Megan is the Director of Business Development at Personal Touch Home Care, and Keith is the Director of Business Development at the Meadowbrook Care Center. So, home care and nursing home and the path in between. So welcome everybody, and I'm going to turn the program over to Megan.
Thank you so much for having us, and thanks everyone for joining us so early this morning. We're excited to be here, and I think it's, I can candidly say it's a unique scenario to have a business developer from the home care realm and a business developer from the nursing home realm kind of work together. And to Sarah's point, that's why we call ourselves the healthcare dynamic duo. We are what you call mission driven. We're not out to, steal someone over to the home care side or steal someone over to the nursing home care side. We're just looking to get people, the ability to thrive in the best way possible, because every individual, as we know, is unique. Not everyone's going to thrive in a home care environment, nor in a nursing home environment. So what we'll go over today is first, obviously, from my portion is what home care provides, just at its core. And then also the different methods of home care, because there are actually different types of home care that you can choose, and also how to identify if an individual is fit for home care, because some of the items might actually surprise you. Some people are not fit for home care. So I'll just begin my PowerPoint slide now. Excellent. So as Sarah said, my name is Megan. I'm the Director of Business Development over at Personal Touch Home Care. And thanks again so much for having us today. Okay, so as mentioned, let's just first go over what a caregiver in the home care realm actually provides assistance with. You'd be surprised, some of our clients at the core only want to receive companionship, and that's something that we do provide in home care. So think about things like playing a puzzle with an Alzheimer's client, or playing cards, or taking them for a walk, things like that, just engaging them. That's just numero uno, what home care attendants assist with. Number two is something called IADLs. That stands for Incidental Activities of Daily Living. So when you think of these items, think of things like escorting to medical appointments, running errands, grocery shopping, picking up prescriptions, but also assistance with light housekeeping skills. So laundry, dishes, vacuuming, sweeping, and dusting. Beyond that, home care attendants also provide assistance with activities of daily living. So think about toileting, dressing, bathing, meal preparation, feeding, grooming, and medication reminders. So something interesting to keep in mind about home care is the home care attendants can only provide assistance with medication reminders, not administering medication. So that's a kind of a fun fact that people often forget, that they are not technically a clinician. They're not allowed to administer the medication. So if you have someone who requires insulin injection, that client has to be able to independently do it themselves. All the caregiver can assist with is just the medication reminder. Oftentimes, I find that people, are interested in home care services because they think about the adult child looking for home care services for their aging parents. Maybe the adult child is fine doing the IADLs, right? The escorting to medical appointments, running errands, but it's those ADLs, those activities of daily living, such as the toileting and the dressing and the bathing, that sometimes the adult child does not really want to assist with, and who can blame them? So I always say, let a professional come into the home and at the very least assist with those items, so that the child and the parent can regain their relationship as it should be. Okay, so why do individuals choose home care? I think it's pretty obvious. People want to remain in their beautiful homes for as long as possible. They want to be independent. They want to thrive within their community as long as they can. They want to have the privacy that home care provides. And the great thing about home care services through a licensed home care agency is that there is a supervising clinician who supervises the caregivers and makes routine assessments for the client. If there's any ever serious change in clinical condition, a deterioration, or even if just by request by the client, if they want to see a nurse because something is running amok. So our nurses go out, and the licensed home care agencies, they all send out nurses at a certain frequency. Usually it's 60 days, sometimes it's 90 days. So there's so many different forms of home care. And I always recommend that whenever you're looking for a home care agency, do your homework. I'm not sure how many of you actually know, but there's over 800 and increasing agencies in New York alone for home care agencies. And I always liken it to the fact of, imagine you were looking up a dog groomer, for your dog, and you go on Yelp and they give you 800 reviews in your immediate area, or 800 choices. Where do you even begin? That's overwhelming. So what I say is, just like you would go onto Yelp or Google Business to do your due diligence, do the same thing for when you're doing your research for home care agencies. So go to their social media profiles, whether it's LinkedIn, Facebook, Instagram. Some of them have Pinterest, and also Google Business, which is huge. Also, you want to make sure that the home care agency that you're looking to enroll with for you or your loved one is licensed by New York State Department of Health. Trust me, there are many of them that do not do things above bar, so to speak. They're kind of sketchy. There's Medicaid fraud and other things going on. So you want to make sure that they are licensed. And when they're licensed, New York State Department of Health has to go in at a certain frequency to conduct audits, checks and balances. And that gives the community peace of mind knowing that they're doing things by the book. You also want to make sure that the agency that you choose has proven themselves as knowledgeable, reliable, and responsive. The biggest feedback that I receive from people who I speak to on a daily basis is, wow, you're the only one who actually answers my phone calls or responds to my phone calls. And that's disheartening because, so much of the community has maybe a negative experience with the home care agencies that they've dealt with, but, it's just all about finding the right person at the right home care agency. So there are many different forms of home care options that an individual can choose from, right? So initially, you can think about traditional home care. That's for an individual who has Medicaid, because Medicaid pays for the long-term home care. And that's the traditional route, means that it's the agency that sends a caregiver into the home. And the client enrolls, we send a caregiver into the home. We are then responsible as the agency for scheduling the caregiver, assisting whenever there's a caregiver call out, completing their payroll, and keeping up with their compliance items, such as the physical that they need on an annual basis and other things. Then there's another option called CDPAP, which is an acronym. It stands for the Consumer Directed Personal Assistance Program. I'm sure you've heard of it on commercials and on the radio and TV. This is the model of home care where you can hire a loved one to be your caregiver. And a lot of people love that. However, there is a huge increase of responsibility on the family side or the client side when enrolling into CDPAP. So in traditional home care, to backtrack for a second, it's the agency who is responsible for hiring the caregiver, scheduling the caregiver, and supervising the caregiver. In CDPAP, it's either the client or the family's responsibility to do those items. Find the caregiver and hire them, train them, supervise, and schedule. So I always say CDPAP is right for some people and not right for others, because if you're what I endearingly call a helicopter family and you're on top of everything and you've got files organized, in regards to the home care needs and home care services, maybe CDPAP is right for you because you want to be overly involved. But if maybe you have a family member, if you are a family member living out of state, out of New York State, CDPAP is probably not right for you because you can't really realistically train or supervise the caregiver, right? But CDPAP is great for people who want a little bit more autonomy with directing their care. Then, of course, we have what we call CHA services, also an acronym. It stands for Certified Home Health Agency. And what that agency does is it's for short-term home care services, as well as skilled nursing needs, such as physical therapy, occupational therapy, and wound care. It's only for people who have Medicare. The last option is what we call private pay or self-pay, and that's for people who choose not to use their Medicaid or don't have Medicaid or Medicare and want to, have home care services.
Megan, stay on that slide for a moment. We have a really great question for you.
You got it.
Can you talk a little bit about the coordination of care from coming out of, let's say, the hospital and getting the CHA services and then transitioning, let's say, to the consumer directed program through Medicaid and how you support that family in getting that consumer directed in place?
That is such a great question, Sarah. What I like to say, it's almost like, you ever hear the game as a child, like the floor is lava? So I kind of liken it in home care of, as soon as a client comes out of the hospital, keep them supported for as long as possible with whatever needs available. So kind of like keep them above. So if someone's being discharged from the hospital, although I'm specifically on the licensed home care side, perhaps they don't want long-term home care services immediately, or they don't have Medicaid initially. Maybe they're applying for Medicaid. So what I do is I send out a referral, as long as the family speaks to me, I send out a referral for CHA services, which is bullet number 3, the short-term home care services. And it keeps that client supported for a short period of time. Usually it's called episodic. So it's usually about 4 to 6 weeks of short-term home care services. So we keep them supported for about 4 to 6 weeks while they're applying for Medicaid, kind of in unison. Then hopefully once Medicaid is approved, then the CHA services go away, and then we can start with either CDPAP services or traditional home care. Does that answer your question, Sarah?
Yes, that's great. And also with the consumer directed, even if you're looking for your own home health aide, you can use a licensed home care agency that has a consumer directed program to be able to support you on the billing end and to be able to explain the process. So whether you're using the traditional route with the licensed agency providing the home care aides, or the consumer directed where you're locating your own team to be paid by Medicaid, you can still have support from a licensed home care company.
And you can enroll into CDPAP, and perhaps if it's too overwhelming, no big deal. Now you just transition over to traditional home care. You're not set in stone. There's no kind of liability if you switch. So you can hop around as much as you please.
Exactly. That fluidity is a really important part of the process. Yes. That you're not stuck in one box. You can go from A to B and back.
Exactly. And then just a little tip on the right-hand side, if you want further clarification with any of these different options, feel free to call me. My phone number will also be on the last slide as well.
And we also will answer questions as they come in. So we actually had another question come in on the community home health services, the CHA services through Medicare. So the question asker says, CHA accepts Medicare, commercial insurance, and Medicaid as well. Can you explain if Medicare consumers are eligible for it if they're homebound?
They are eligible for it if they're homebound. The whole purpose is to keep them within their homes. Perhaps the question is, you do need a doctor to sign off on those services. And I actually have connections with different visiting physicians, different companies called Vis-a-Vis and Essen, where they can send out a doctor to sign those MD orders so that CHA services can begin.
So if one needs CHA services, where do they start?
Call someone like me. And then the referral always has to come from a clinician. So that's why I would then enlist either Vis-a-Vis or Essen, one of those visiting doctors, or I would proactively reach out to the primary care physician for the client to get them to sign the MD orders and specifically the needs that the client has, whether it's PT, OT, or wound care. And then we get the services started.
Terrific. Okay, so we have a couple other questions that came in from you. So when reaching out to a home care company who's going to provide your aid, does the company ever provide consumer references that they can speak with? The question asker says that Yelp is hard to rely on.
Mm-hmm. So if I understand the question, if you're going through the traditional home care route and we're sending a caregiver into the home, I think the question is asking, do we provide the references for the caregivers?
I think the question is, do you ever provide a reference where new family A can talk to existing family B about their experience?
No. However, I do recommend that you look at our, any agency, specifically our Google Business account, because that's where you can find real user reviews, whether it's clients or employees. And I always say, a happy employee equals a happy client. So.
And with the referrals internally, there's HIPAA protections where a licensed home care company, they can't disclose the name of their patients.
Of course.
So we have another question. When do you feel it's time for your client to go into either assisted living or nursing home when they're receiving home care?
So as I mentioned, our clinicians go out at a certain frequency, either 60 days or 90 days, or if there's a serious change in clinical condition. And the next slide, we're actually going to mention what to look for if the client is perhaps no longer really fit to thrive at home. And Keith is going to also go over his part. There are certain things that our clinicians and also my team look for because my goal is to keep them in the home as long as possible, but there are certain items that if I see, it's kind of like a red flag. And then we start the transition over to a nursing home or an assisted living.
But it's also a process that the family is deeply involved in. There's no one answer, there's no one path. But that's why the professionals from home care companies and from nursing homes and our care managers and our elder law attorneys and our other like-minded professionals are here to help you answer those questions on your own personal path.
Exactly. Okay, so here's, I think, what everyone was looking for, which is how to identify if an individual, which method they're going to thrive best in, whether it's home care or the nursing home environment. So home care may not be the best fit if the client has skilled nursing needs. Yes, I just mentioned that CHA services, Certified Home Health Agency, can assist with some skilled nursing needs, but not all of them. They can only provide some assistance with, trach care, feeding tube, PT/OT, wound care, things like that. If it goes beyond and more heavily involved than that, perhaps they're not right for home care services. Secondly, if the environment is not fit for home care services. So you might be surprised to hear that so many of our clinicians actually go out to the home with every intent of starting services, on that first day, and they might see that the client is a legitimate hoarder. Well, then we know that is not a safe environment. It's a safety hazard for everyone involved, the caregiver, the clinician, and the client, and the family. And beyond that, they look for things like, are the utilities on? Is someone actively paying the bills to keep the home, flowing for everyone's safety, especially, think about the winter time. Is someone actively paying the heating bill, things like that? Also, do they have a working phone? There was a client recently that we tried starting services with, and they don't have a working phone. That's a huge risk. What if there's an emergency in the home? Yes, the caregiver, brings her cell phone, but what about off service hours? Or if God forbid there's a service issue. So we look for all of those things. Additionally, if the client is heavily combative or an elopement risk, what elopement means is if someone is, looking to escape the home with no due cause, so sometimes Alzheimer's patients, dementia patients, even, individuals with autism might have this elopement behavior. And I do see that some families put like a high lock or like a keypad lock very high on the door to assist with preventing the individual from escaping. However, it's kind of a twofold thing because yes, it's protecting them and keeping them in the home, but there has to be a method for someone to escape the home quickly if there is an emergency, like a fire or something. So that's something that we look for as well. Now here's the big one. I'm sure everyone's heard about the caregiver crisis. The caregiver crisis is huge in New York right now, specifically upstate New York and east end of Long Island, Suffolk County. If there's no aid availability, there may not be anything that we can do to provide the home care services. However, Personal Touch does have other options to provide caregivers if we don't have an active caregiver on our roster specific to someone's area. So say we were looking for a caregiver in Kings Park and we look through our active roster and there's no one in the vicinity of the Kings Park, Suffolk County area. What we would then do is, the good thing about Personal Touch is we've been approved through New York State Department of Health to provide a condensed 2-day training program. It's called an ACD training program. It stands for Alternative Competency Demonstration. And what that means for the client and the family involved is if we don't have a caregiver on our roster who can go to Kings Park, I then circle back with the family and I say, listen, if you can identify someone in the community, whether you find them on care.com, a Facebook group, in your church, your neighborhood, someone who's willing to be a caregiver, just cannot be a family member. If they're willing to be the caregiver for this client, have them enroll with our 2-day training course, which is free, and we hold them all throughout our territory, Long Island, the boroughs, and Westchester. Then they're trained and certified, and they can start working through a licensed home care agency like ourselves. So that's a great option. And in that way, the client still receives traditional home care services. It's not CDPAP. And a lot of people prefer the traditional home care services because, like I mentioned before, it's the agency who has the heightened level of responsibility, scheduling, training, supervising. Then the third option, of course, is offering CDPAP, which is that helicopter family. If as I endearingly call them, if they want to dive into CDPAP, that's another option as well. And that's really great for those hard to service areas. So the next bullet point is someone's not fit for home care if there's no family backup in place. Any licensed home care agency before starting services requires that the family and or the client signs, some standard admission paperwork. And in that paperwork, there's always a clause that says there must be family backup involved in the case of a true emergency, like a hurricane, winter storm, things like that, because those things happen. And so many of the caregivers, candidly speaking, take public transportation. So if there's a true emergency, as rare as it is, there does have to be family backup in place. And lastly, home care may not be the best fit if the approved home care hours through the managed long-term care plan or the local Department of Social Services does not cover what the client or the family thinks that they need. So for example, say the client and the family want 7 days of live-in services. However, Medicaid has only approved them for 8 hours a day. This could now be a safety hazard, and to have that client staying at home, because then the caregiver would come and leave, and the client would be alone throughout the evening, which could be a safety risk. So what I always recommend to the community that I speak to is speak to me prior to having any nursing assessment in regards to the approval for home care hours. So the state will send out a nurse to assess the client and approve them for a certain amount of hours each week. Speak to me prior to that assessment so that I can help prepare you with what the nurse is going to be listening for. Is there certain verbiage that she's going to be listening for? Specifically how to say things to best describe the client's worst day, because you really do have to describe the client's worst day for the state to really fully understand what it is that the client needs assistance with. So I always just say, loop me in at the very beginning. That way we can help to ensure that the client receives, the maximum amount of fair hours that they deserve.
Megan, we have a question that just came in, and the question asker is saying, can you get nursing home level care at home to give medication to a patient, such as eye drops, injections, or oxygen?
You can do that through CHA services. However, I know that there are certain CHAs that only provide certain skills. So I can't say across the board that they all provide those skills, but certain ones may.
And would that be for permanent care? Because the question asker is asking if those things can be delivered permanently, not on a temporary basis.
It's only temporary. So what I see a lot of times is people may pay privately for private duty nursing services, but that can be very expensive.
So for this particular patient, they could get home care, temporary CHA services if the person, let's say, was just hospitalized, but those skilled needs like the eye drops, the oxygen, and the injections would have to be done either by a trained family member or the person would need a higher level of care.
Correct. Or they could pay privately for a private duty nurse.
Thank you.
And that sums up my presentation. Again, this is my contact information, our social media platforms, because remember, I recommended do your due diligence, do your research, look up the agency that you're looking to enroll with, call me anytime. And I truly mean that. Keith and Sarah and Bruce can attest. You can call me after business hours, including weekends. I'll always answer.
Thank you very much, Megan.
Thanks so much.
And if anyone has questions for Megan, please enter them into the chat or into the Q&A so we can make sure that we address them. And we'll answer those questions at the end of the program. So please welcome Keith Singh from Meadowbrook to talk about nursing home care.
Hey guys, just gonna share my screen. Okay. Hope everyone would see that. Hi, everyone. My name is, once again, is Keith. Today I'm representing Meadowbrook Care Center, which is located in Freeport in Nassau County. We are a nursing home, and we, as I'm sure you've heard, we definitely have been in the news, not just my place specifically, but like nursing homes in general in the past year and change. So we'll be going over questions regarding COVID and post and so on and so forth, and kind of like that. So let me get started. So industry professionals know nursing homes under a different acronym that you might have called in the past, which is a SNF. It really just stands for a skilled nursing facility. There are many different terms and that are used to address a nursing home. Ideally, at the end, they're all pretty much the same thing. You won't find a SNF or a nursing home that isn't a short-term or isn't a long-term or doesn't have a skilled nursing facility or some type of rehab. They're all under the same umbrella. The only real difference is really where the nursing home places the patients inside the nursing home. Now, it could be on a floor that's just for short term. It could be on a floor that's just for long term people. At the end, it really is the same thing. People ask, because it is an SAR, a SAR, a subacute rehab, what's the difference between an acute rehab and a subacute rehab? Now, the actual answer that most people don't know is that there is really no difference. The only difference is that when you're in an acute rehab, it's usually located inside the hospital that you're in. And it is nice that you go from the med floor directly in a wheelchair or need be a stretcher to the acute side of the rehab of the hospital. Besides that, same exact rehab is performed. They might have, usually have the exact same type of equipment that subacute rehab has. The only difference is whether or not that acute rehab really takes that patient or that resident's insurance. Usually it's only for 20 days and they're usually gone on day 21 from an acute rehab. And what it usually is because that Medicare, the patient usually 99% of the time has to have a straight Medicare plan or a traditional Medicare plan. And from there, after on day 21, that's when the copay needs to be kicked in. And a lot of places don't like to deal with it. Hence why day 21, they're gone over to a subacute rehab. There really is no difference. You could ask almost anyone in any rehab what they think, and they'll probably tell the exact same thing. So why a SNF, a SNF, as I'll just call it, because it's usually just what we call it in industry. A SNF, sometimes people need a higher acuity of care, and acuity of care just means a higher degree of care. A professional who's comfortable with performing what's needed for the patient versus the family. It's definitely helpful when you have a team of people rather that are fully at the patient's disposal, rather than sometimes home care where it's just a one professional that's sometimes there, and if they don't have 24-hour care, then there are some times where they don't have a professional on site. Sometimes, kind of like what Megan was saying earlier, some dementia diagnoses can cause a need for a SNF. And usually it's when you have a family member or the resident or the patient that's at home, they can't really, they're a possible an elopement risk. And what do you do? Maybe you don't have 24-hour care. Maybe they don't qualify for it. Maybe you can't afford it. Maybe you're not able to stay home. It's tough. And something like that usually would require a secured dementia unit, where it can be locked, or they can have a thing called a wander guard, which goes on their wrist or their ankle, and it can alert the floor if they ever wander off the floor. And even if they find their way onto the elevator, The elevator won't go anywhere until that person is cleared from the elevator, a code is entered, and from there it gets released. Inpatient rehabs also offer more variety of therapies. So for example, they have 7 days a week compared to home care, which might not be 7-day a week rehab. We have a whole gym at our disposal rather than whatever a home care physical therapy company might be able to travel with. On top of that, there's also supervision. Something happens, you're calling 911 at home. In a nursing home, not so much the case. We have everything from, the CNA on the bottom to the doctor up top in the facility able to assist. And we also offer physical therapy, speech therapy, and occupational therapy, which definitely can help. Another reason is if the family is unsure that they're able to achieve the PLOF, which is, in other words, the prior level of functioning. If the family is unsure that they think that they're able to get that patient or that resident back to where they were, or they're not confident enough, then we definitely would suggest a sniff. If you need long-term care, the patient needs long-term care, 24-hour care, it's definitely a cause to be at a sniff, as well as like what Megan was saying earlier, with the caregiver crisis, it's really hard to find home health aides in upstate, in Eastern Long Island, and so on and so forth, that if that's the case, then probably a sniff is a good way to go right now. Also, they might not have any support in the community, as we always say. They might not have a significant other. They might not have family. They might not have a best friend. They might not have a good neighbor they could always rely on. If that's the case, then I would definitely suggest a sniff. Now, on the contraindication of a sniff, why not a sniff? Why not a rehab, a subacute rehab? So there's a bunch of reasons. The resident might have finished their rehab and gotten better. If the patient is doing jumping jacks in the hallway, they probably don't need a sniff, A lot of times post-operational from the hospital, they are on IV antibiotics, and sometimes they finish it with enough time before discharge from the hospital. Then guess what? You probably don't need to be at a sniff. Back in the day, total knee replacements used to always go to a sniff. Now, not so much. They rarely ever go. They don't need to. They can be done home care, and so on and so forth. The biggest thing that any therapist would tell anybody is, can the patient who obviously is the most important cog in the wheel here, do they understand their limits? Does the therapist think that the patient might not understand that, listen, you can't walk more than X amount of feet, or please don't rotate this way, please get up this way, please make sure you have help doing this. If they don't think that they can understand their limitations, then they should go to a sniff. If they can understand the limitations, then it usually isn't a problem, that they can go home and get rehab via home. As I was saying before, if you have a patient who's ambulating 100 feet without assistance, then I would say, like I said, you're pretty much doing jumping jacks in the hallways. You're pretty fine by that.
Keith, we have a question that
Sure.
came in,
Mhm.
and our participant is asking, for dementia patients, what is the difference between a memory care facility and a skilled nursing facility?
So, good question. It depends on the facility in regards to, do they have, for example, a secured unit, a locked unit for dementia patients. Now, it varies on state to state. In New York, for example, you would have usually a second or third floor unit and up. You might have 8-9 floors for a sniff, but it's usually not on the first floor, because you want to make it harder and harder for that patient to elope. Now, it could be a locked unit where you have to enter in a code. It could be not a locked unit and they have a wander guard on, like I said, on their wrist and on their ankle. And that is usually the difference between being able to take a dementia patient that can ambulate to one that cannot. If you have one that's bedbound and they have dementia and so on and so forth, then you really don't need to worry about that as much as if they're able to walk no problem without assistance. And next thing you know, they're on the turnpike. Okay. And it happens. And some states are more stringent than others. New York luckily is. However, when there's a will, there's a way. And, you know, there's a lot of steps in the process to make sure that they don't get out. But, you know, it is what it is, sadly, sometimes.
A little piggyback question to that, Keith. Between a memory care facility and a skilled nursing facility, is there a difference in terms of the cognitive and behavioral stimulation provided to the patient?
Yes, that usually entails the therapy and the recreational side. So there are more programs um, oriented toward memory loss and lower cognitive function compared to the opposite of it. Is my answer to that.
Okay, we have another question coming in. Lots of questions for Keith. So this one's pivoting just a touch, and our participant is asking, is there still a 3-day hospital stay required to qualify for rehab in a skilled nursing facility covered by the Medicare program?
Sure. So I actually covered that in the next couple slides, but I could answer that question right now. As of this present moment, there is not. So just to go back a little bit, if you have a Medicare as your primary insurance, a straight traditional Medicare, you were required to have 3 midnight stay in a hospital, not just in the ER, but admitted to the floor, any floor in the hospital that isn't considered the ER. And that kind of, they passed something, I want to say in April of last year, which was called the 1135 Medicare waiver. And what that was meant to do, it was to try to keep, for obvious reasons, people away from the hospitals that didn't need to be there, to try to, you know, curb the transmission of COVID. So what happened since then with the 1135 waiver is that now they can go, instead of having to stay in the hospital for 3 days, now they can go straight from home with the right proper documentation directly into a nursing home, which helps a ton. Also, for the fact that sometimes people didn't need to go to a nursing home after discharge from the hospital, but did after a while, and there was a certain amount of time that needed to be within that window in order for you to say, okay, I was at a hospital for 3 days. Now I can, you know, within the last certain amount of days, and I'm still within a window where I don't need to go back to the hospital, but I can go to the nursing home because I'm before those certain X amount of days. Now that also kind of, I guess, shortcuts that, where you don't even have to worry about it. If it's been 30, 60, 90 days since you've been in one, go straight to a nursing home. All right. And lastly, I guess the last two things is why not a SNF? Certain places are different. The places that I personally oversee, if the patient is exhibiting combative behaviors, not just toward the staff, but most importantly toward other residents, they need a very special, usually some type of psych facility. It could be a psych hospital. In a psych hospital, they could be there for years because there's not really a place that will take them or that is appropriate for them, and so on and so forth. Or as well as if the patient needs to be on a one-to-one supervision. In the hospital, a lot of patients are, and they have the ample amount of staff to be able to supply that. I've seen personally that, you know, you could have more than one gender in one room if you have a patient on a one-to-one, because you have the supervision there and so on and so forth. In a nursing home, rarely ever happens where they have the ample amount of staff or they're willing to just pay the extra amount of staff to do that. Prior to COVID, you might be able to provide your own. The resident might be able, or the family might be able to pay for their own aide to sit there with them 24 hours or however many they needed. During, post, or whatever you want to call that we're in right now, not really the same. Even if the patient's family comes around and says, hey, listen, I'll pay for it, get me someone else, it's really tough to find, because kind of what Megan was saying earlier, not just in certain parts of New York, but in what I'm seeing personally in the nursing home is that throughout the country, we're going through a caregiver crisis, and New York is no exception. And it's the biggest problem next to census that we're dealing with right now, that we can't find help in the nursing home. So much so that a lot of states are lowering the amount of required licensed healthcares in the facility per 24 hours a day, because it's just so bad right now. So that's that. So you might have a client or so on and so forth, or family members, client of a family member, so on and so forth, that needs to get started toward a SNF. And there's a lot of different ways to get in. The first thing is that you need a PRI. Now, what a PRI stands for, usually most people in nursing home don't even know what a PRI stands for. However, it is the number one document that's needed to get into a nursing home. It stands for a patient review instrument, or just a PRI. It needs to be completed by someone who's licensed to do that, or it can be done in the hospital, it can be done at home, and it has to be someone who's definitely designated to fill out a PRI specifically. That being said, it's not only a PRI. If you're not at a hospital, then you're going to need, or regardless, even if you are in a hospital, you're going to need an order from a doctor, or specifically, let's say even in a hospital, a therapist, a rehab therapist can definitely give one of those, or suggest it, and it kind of goes from there. As well as at home, they can get the personal doctor to kind of curtail that, as well as a complete financial background check. If they're coming for long-term, for sure. If they're coming for short-term, there are usually ways around that. You might not even need your Medicaid secondary to kick in, or an MLTC to kick in, because you're only here for a short term. Could be here for 5 days, could be here for 100 days. It really depends, and so on and so forth. Now, does that come with a copay? Yes. Some places waive the copay if they see, the benefits outweigh the risk. Sometimes it happens. I definitely do that every now and then. Other places might not. But the easiest way, if you have a patient who is home that needs to go to a SNF now, especially with the 1135 waiver, or before the 1135 waiver, I would have said, is go directly to the hospital. The case managers there, they take care of everything, and they're able to do, it's a one-stop shop pretty much. And even with the 1135 Medicare waiver, sometimes it still is easier to go to the hospital and have them take care of everything. Okay. So the biggest thing that I'm sure everyone, is what's going on with COVID, the adaptations during the COVID era. Because up until recently, very recently, I'd say probably middle of last month, my one, let's say, Meadowbrook Care Center wasn't taking in-person visitation. So we started a whole concierge program this past year to kind of, connect the dots between the family and the patients inside the facility. And it was very tough. Luckily, it's worked out very well. 7 days a week, we're available to the families. We have people on site 7 days a week. And it kind of bridged the gap that we noticed was missing and it's really tough when you have someone in the facility and people haven't seen them for a year, and to know what's going on, or someone's not able to pick up because the nurse is on the floor and yada yada, kind of really helped a lot. And we've expanded that to other facilities that I help oversee. Another thing that's specific to Meadowbrook Care Center is that we do offer full vent care. A lot of places don't. Majority of places in New York don't, with a 24-hour respiratory therapist, and it's very, very needed. If pre-COVID, I'd say most of the vent beds were usually taken. I'd say usually 80 to 100% capacity. Since COVID, it's been 100%, to the point where we've even expanded it and added a couple extra vent beds because it was so needed. All our staff is still swabbed twice a week. Just today in New York, I'm sure most people have heard that the mask mandate has been mostly lifted in New York, praise be. However, we still are required to be swabbed twice a week. I will say that not to talk down on hospitals, but since the pandemic started, hospital employees, regardless of who you are, just like in the nursing home, have only needed to be swabbed one time since the pandemic started. Since compared to us, which we've probably swabbed well over 100 times, twice a week, like clockwork. And we've come to notice that when someone hurts themselves or they need to go to the hospital, so on and so forth, that miraculously they come back with COVID, or they test positive for COVID while they were there. They didn't have it prior to us, or sad to say, they've come back so quickly, but they acquired it while in the hospital. And most of the time that we've learned is that it comes from the healthcare workers, and it's really tough when you're dealing with a crisis. And I'm sure the hospitals have dealt with their own, but they acquire COVID in the hospital because it's just never required compared to, let's say, what it is in the nursing homes. Is it fair? I don't think so. Should they have done it? Definitely, but this is just how we live. Another thing that we definitely do is every 2 weeks we offer the Pfizer vaccine. We're starting to slowly move over to the J&J vaccine because it's a one and done, and it's just a lot easier with regards to logistics and so on and so forth. But it's definitely wonderful because it's offered just so readily available, as well as sometimes we have people that come in with the Moderna and they need a second shot. We can offer that as well.
That's terrific. Yeah. So we have a participant who we've been chatting with, who has a family member with a very high level of care needs, but they're really very hesitant to enter into skilled nursing care because of everything that's happened during the COVID-19 pandemic. Sure. And it seems like a lot of what you're talking about should make those fears be put at ease a little bit. What else can you tell that family about putting their trust in a skilled nursing facility to take care of their loved one?
So the number one that I would suggest to the family is make sure yourself as well as your loved one is vaccinated. Obviously, pre-vaccination, which we started, our first vaccination clinic was on December 26th. Then, I mean, you heard the stories and most of them were all true. We had a lot of deaths in the nursing home industry, mine included, and it was bad. Now, you could see the effects of the COVID vaccine, and it's just, I think we've had 0 deaths for any patient that's been vaccinated for COVID. On top of that, there are a few that are hesitant to have their loved ones vaccinated. So what we've kind of been doing to trying to curtail that is to not keep non-vaccinated residents together. We try to keep them with someone who has been vaccinated to kind of keep them protected, just in case someone, the other person one has it, the other person might get it also. Now it's not so much like that whatsoever. We've had, I can't think of one expiration because of COVID for a person who has been fully vaccinated since then. Now we're also, which is my next bullet point, we're offering in-person visitation, and even to the next bullet point, it does depend. There are different guidelines for visitation. If you have been vaccinated, if the family has been vaccinated, have they both been vaccinated, as only one, so on and so forth. And it's for their safety, quite frankly. And it's been going really well. Luckily, I would say a lot of the patients' families are vaccinated. We try to do it outside as much as possible, and especially on beautiful days like today, and so on and so forth. And I really think the swabbing twice a week, and at least I could talk from Meadowbrook Care Center, that I'd say at least 75% of the facility has been vaccinated, and we have still more and more people staff-wise that are getting vaccinated every clinic, because they see we're not dying from the vaccine, like the hesitancy that might have been there in the beginning. Not so much.
Keith, and that's really terrific. And yeah, if there are any participants or their family members who are homebound and have not been vaccinated but would like to receive a vaccine in Westchester County, Westchester Gov has a program where those homebound residents can be vaccinated at home. So, please reach out to us. We'll connect you with a representative from Westchester government about getting that loved one who is homebound a vaccine.
Yep. I can't tell you, like, I know, I hate to sound, I don't know, run the risk of sounding political, but it's not a political problem. It's just get the vaccine. It's safe. The proof is in the pudding. The numbers are there. And as you can see, I mean, New York State has lifted the mask mandate as today, which is amazing, if you ask me. And that really goes to show you, considering that New York was probably the worst hit out of all 50 states, I would say. And maybe without, including India and a couple other places, the same. So I'm very happy with the numbers, as well as Department of Health in New York. So yeah. And that's pretty much it for me. If you guys have any questions, you want to, run some stuff by me, give me a call. That's my cell phone number. And I'm always here to help, even on the weekends, just like Meg.
Great. We have some questions that are coming in. So Keith, if you can, when you have a second, to stop sharing your screen, because this one is for Megan and I want her to pop back up. Very good. Thank you. So question for Megan. My mother had a home health aide from a large licensed New York agency, and she had multiple aides for the coverage she needed. One of the aides on their shift, a significant amount of property disappeared, and I wasn't really sure what to do about it because the agency couldn't acknowledge it. They made a police report, but what kind of things can be done to, prevent something like this from happening when there's care in the home? And are there ever background checks that the agency could do or the family could do on the individuals coming into the home?
I'm so sorry that happened. That is just so violating. But what any licensed home care agency is expected to do, it's part of the policies and the regulations from New York State Department of Health, is to complete a background check for all caregivers before they start working. We also do require at least 2 caregiver references, from professional references. Beyond that, our policy is similar, that we recommend that the family file a police report. We also do a very heavy internal investigation. These things happen, but I also recommend that if it were my own grandmother, I would have something like a nanny cam in the home, and all that's expected from the family or the client is just to make that be known prior to the start of services, so that we can let the caregiver know, so that everyone is kind of on the same page and they're not feeling violated themselves, just that there's a camera in the home, like some kind of security camera. And more often than not, it's not going to catch anything from, actually happening, but it's going to help deter bad behavior.
Right. And if you do use a camera or a nanny cam, they have to be visible. The aide has to be aware, and they cannot be in a private place like the bathroom or where any private function may occur. So in open public spaces. Okay. And Megan, we had a participant who just wanted to hear more about how to get CHA services in the community from a physician referral. So you can speak a little bit about that.
Sure. Just like Keith mentioned, there's something called MD orders, or doctor's orders, for really any kind of healthcare services. So, the nursing home facility needs MD orders. Traditional home care services needs MD orders, so does CHA. So we always recommend that it's the easiest way to go about it is to have your primary care physician complete those MD orders. And it acts essentially as a prescription for the services that individual needs. And if, like I mentioned, that client can't get out of the home to visit their PCP, their primary care physician, then you can work with an organization like Personal Touch, and we can coordinate having a doctor visit them within the home.
Okay, so a follow-up on the other question. Does an agency have to recommend the use of a nanny cam, or is that more just consumer research?
That's just my own recommendation, but I wouldn't say that Personal Touch as a whole recommends it, but if it were my own family member, that's what I would do. And I work with so many families, the geriatric population, the special needs population, and just across the board. That makes me feel good. We even have, my husband and I have cameras in our homes just to watch the pets. I just think in this day and age with the technology that we have, why not use it? And then it keeps everybody kind of above bar, so to speak.
And to add to that, just we kind of have the same problem, let's say in some of the nursing homes, not that problem per se, but where the family wants to watch this and that. And it can't hurt to ask. The worst they can say is no. It usually just does vary from facility to facility and who's asked. So don't be afraid to ask, call up the administrator and say this family member wants this. And, right now in, my little tidbit of information is that a lot of places are hurting so badly that they probably say yes to it rather than how it was prior to the pandemic, where it really was a yay or a nay or how I'm feeling today. Yeah, sure. Let's do it for them. A lot of places definitely do it. And it's definitely scary for the CNAs and the nurses, but it should be, I feel like, and it definitely can protect the patient as well as the facility, to be honest with you.
It should only be scary for the caregiver is if they're doing something wrong, right?
100%.
Right. I think that's great because it puts families in charge of their healthcare. So it's almost taking them from being a patient, which is a passive role, to being an active consumer. So they're a participant in their own care as well as the family. And that's what, we're here to help you do. What Megan and Keith and myself and the Senior Law Day Collaborative are here to provide information so you and your family can be an active participant in your care. So we have actually a really fun topic question that came in. So Keith, can you talk about discharge planning? So you've had a really successful rehab. The patient is ready to go home. The family is excited, but they need home care. How do you coordinate with someone like Megan to make sure there's proper home care in place?
Sure. So discharge planning is really really falls on the social work department. They have people that are preferred. However, it really is 100% up to the family as well as the patient, obviously, if they're able to talk for themselves. We, like I said, we would only suggest one that we've worked with in the past and that we know there's no problems with and we have a good reputation with and a good standing with, and we can see that they're not going back to the hospital or back to the nursing home a week or two afterwards, that they're doing their job and so on and so forth. So we usually do a little warm handoff to the next someone like Megan's company over there at Personal Touch to kind of help with that. And it kind of is like I said, the handoff and the continuum of care. A lot of places sometimes offer their own. A lot of hospitals say, after you're done with this patient, send them back to us to our own personal home care, or you can only use our own home care. And that's really frowned upon, at least from my side, as well as should be from the patient side, to only use us or face the consequences type of thing. So it's definitely up to the patient's family for them to do their own research and find someone like Megan's company to say, hey, you know what, I would like to prefer to use, Personal Touch rather than XYZ company.
Sarah, this is a good question. And I love how you posted it like a scenario, but this actually happens all the time with Keith and I. We have each other on speed dial, and there are instances where someone is not fit for home care services any longer. And then I do the warm handoff over to Keith and vice versa. So it happens all the time.
Terrific. And are there other services that you recommend that a family put in place for home care, like a geriatric care manager?
I do. I highly recommend a geriatric care manager. I have a whole laundry list of people that I trust, to refer to throughout the entire territory that we service, Westchester, Long Island, and the boroughs. I recommend that specifically for the geriatric population, but then there's also other supportive resources, programs for the special needs population. So if that's something that you're interested in as well, these services are covered under Medicaid. So if you'd like, just reach out to me and I can go over in depth the other supportive resources.
Great. So a participant just asked, hi, Megan. Hi, Keith. Yes, they said hi. My parent was recently discharged from a subacute rehab facility and is in the process of receiving short-term home care authorized by Medicare managed care. So Medicare HMO.
Right.
He will need more home care services via private pay as he does not qualify for Medicaid. How should we begin with private pay services?
Oh, sorry. No, go ahead, lady first.
I think it was for me.
Sorry.
I always recommend, if it was my own grandmother, I would be very conservative, making sure that we start with a large amount of hours each day to make sure that she's safe at home. And then you can always dwindle back the hours. And you're never, in contract to, if you start with 7 days a week of 8 hours a day, we don't make you receive that services until infinity. You can reduce it, you can suspend it whenever need be. But I always recommend, especially when they're being discharged from a rehab or a hospital, and you don't know yet how they're going to be doing it specifically in the home, you want to make sure there's a professional there really at all times.
Okay, great. So another question is, going into either a home care situation or nursing home situation, how do we, as the consumer, have the best experience possible when we're inexperienced in both of these fields? What should we be looking for, thinking about, to make sure that our family member, as well as the facility, have a positive and happy relationship? So, and this is for both home care and nursing home care.
Well, I would say first you have friends in us. You just reach out to us and let us help support you, because every individual is unique. And I always tell the funny story whenever I try to describe to my own parents what it is that I do for a living and the differences between Medicaid and Medicare. Just goes over their head. Don't even know. But that's why it's good that I understand it. And when the time comes that maybe they should need a nursing home or home care services, they have me kind of as their personal touch point person, their home care expert. So you just loop in someone that you trust and who has proven themselves as responsive and reliable, and they can help guide you on your way.
I would say to that question that it really, wait, what was the question again? I'm blanking right now. I'm not.
So you have a prospective patient coming in.
Oh,
and
right.
not emergency, not they're just looking at the facility. How do you help them have a really positive experience, both telling them what to expect and how best to interface with your facility so it's a win-win on both sides?
Right. So I kind of look at it as all these places, without a doubt, are businesses. If you were going to a restaurant, what would you do? Probably Google it. Same thing you should do for a nursing home, for a home care. Google it. Look at their reviews. I mean, yes, can you lie on reviews? I'm sure. But if you have hundreds of reviews, then God bless you. I mean, I don't think you can get that far by lying. And they're all good, hopefully. That, as well as I would say, is the number one factor, no matter how good your nursing home is usually location. If you are living in Montauk, you're probably not going to go to a place in Queens, and vice versa. So I would definitely suggest, be willing to go a little bit out of your comfort zone. If it's worth the drive, definitely. If it's not, no problem. You got to ask yourself, is aesthetics more important than outcome? I'm hoping outcome is more important than aesthetics to you, because it is to us. Even the places that are very beautiful that we have, outcome is the most organic way to take care of your people, to make sure that they're happy and word of mouth in the community.
Okay, we have a question which may be something to say for another program, but can you talk about Ccrcs, which I know neither of you are, those continuing care places where you move in independent and then they have nursing home with a large fee up front?
So I personally don't oversee any Ccrcs, but I can tell you a lot of our competition usually in other states that I've come to realize are Ccrcs, and they are a decent one-stop shop, but I tend to realize they do have a lot more staffing issues. And that, to me, is a very chronic problem. If you're going to have your loved one there and they're always running under in staffing, it's not what you want. You want a place that specializes in this, and if you need, you can move on. There isn't a long waiting list, at least today, even before COVID, to these places, especially if you're going to be private pay. If you're private pay, they're going to make a room for you. If there isn't a room, they're going to make a room for you. There's no problem, So that's my suggestion with Ccrcs.
And my suggestion with Ccrcs is to go, to visit, to ask questions, just like you wouldn't buy a co-op without looking at the books. you want to ask those sorts of questions as well, because it is a big investment for you and your family.
Right. I agree with 100%.
Okay, so let's see what else has come in. Okay, so we have a geriatric care management question. How can I connect with a geriatric care manager to assist my family with navigating home care, Medicare, Medicaid, etc.?
So you can certainly connect with these people. I have a whole list of geriatric care managers. However, the assistance that I provide is complimentary, it's free. And I think I can answer kind of on an equal kind of playing field a lot of the same questions a geriatric care manager would be able to answer. So you can always contact me directly, or I can connect you to someone further if you need other supportive resources like, Meals on Wheels or other things like that. I can connect you.
Or someone going into the home every day or every couple of days.
Correct.
Perfect. And can you just enter your contact information in the chat if you don't mind?
You got it.
Perfect. Okay, so our next question is, what advice do you have for patients that have long-term care insurance with regards to getting covered for home care or a skilled nursing facility? So this is a policy triggering question.
Can you, sorry, can you?
So our question asker has long-term care insurance.
Okay.
And she wants to know how to use it to get coverage for either home care or nursing home care.
So MLTC it sounds like what they have, and it varies from the company that you have the insurance with. I would definitely suggest talking to your case manager as well as to the admissions office in the facility that you kind of want to head toward, and kind of put heads together and to try to figure out, can I, what's going to be needed? Do I need to do a 5-year look back? And kind of go from there. Yeah, that's the easiest. It's very, very detailed.
Right. To Keith's point, different MLTCs have different contracts with different agencies. So I always suggest to families and individuals, speak to your case manager at the managed long-term care plan and ask them for their list of agencies that they are contracted with. However, there are those times that a family member is adamant that they want to use personal touch home care, and we may not have a contract. In that scenario, then we issue what we call a single case agreement, and it's just like a singular contract so that we can provide that individual with services. And that happens frequently across the board with all licensed home care agencies.
Right.
Great. So, and to just address the long-term care insurance piece of that question, thank you on the MLTC piece. So if you have a long-term care insurance policy and you're looking to get home care, care and assisted living, or skilled nursing home care, first you have to look to trigger the policy and what those triggering factors are. So what are your activities of daily living that you need assistance with? And it's always good to call your long-term care insurance provider when you're getting close to needing the policy and to ask for an updated summary of benefit. That's your term sheet that says how much that policy is going to pay out in each of the categories that it will pay for, like respite care, home care, nursing home, if there's an assisted living benefit, so you know your daily number. And if you also have purchased an inflation rider or if you haven't. And that makes a big difference in how much the policy will pay out. And then once you've qualified to trigger the policy, you have to submit medical records, you fill out a bunch of forms, and congratulations, you can use your policy. If you're getting home care, you can assign the policy to a company like Personal Touch or your other care provider, or to the nursing home so that they can pay directly. And you don't have to submit, the monthly timesheets. And if you are looking to get that policy reviewed, there are members of the Senior Law Day Collaborative who can help you with that. So visit us on our website, seniorlawday.info, enter a question in the Ask Us, and we will connect you with an appropriate member who can talk to you about your policy. So if you have any other questions, we've got a number in the chat. Okay. So for Megan, my mother lives with me now, and I provide most of her care. Her mobility is limited, but she can walk. My main concern is if I go away for the weekend, what kind of care can I get for times like that? She needs help mostly with meal prep and just to make sure that she's okay. do you provide services for this situation?
We do, and it's so common, especially in the summertime when families are going away on vacation or, just preoccupied with other things. This happens all the time. And so many agencies have a minimum amount of hours or tasks that the individual must have in order for us to, in order for them to provide home care services. Personal Touch does not have a minimum set required amount of hours. So that's a benefit. And as I previously mentioned on my slide deck, there's a whole range of activities that the caregiver can assist with. At the very base of it is just companionship for things like that, right? Going on walks, meal preparation, making sure that she's eating, things like that. And then, it goes all the way to the other side of the range to those activities of daily living, like toileting, dressing, and bathing.
Terrific. So we have a quick Medicaid question, which I'll address, and Megan, Keith chime in if they're pieces for nursing home or for home care. So the question asker said, what are the current look back laws for both nursing home and home care? So if you need Medicaid in a nursing home, it's 60 months. So that's 5 years of financial records that have to go in to the Department of Social Services, where you're living. So New York City, Westchester, Putnam, Rockland, Nassau, Suffolk. And for home care, the implementation of the look back of 30 months or 2.5 years has again been delayed, and it's expected to be implemented as of January 1st, 2022. But of course, that's subject to change if the Department of Health issues additional guidance. So right now, if you're applying for Medicaid home care, it's a 3-month review of financial records. Okay, so if there are any additional questions, please enter them into the chat or the Q&A so we can address them. And Keith, does Meadowbrook offer or partner with a service for dialysis?
We do, but I wouldn't say partner. It's really hard to find a dialysis center as is, especially prior to this. It was a dialysis center, a COVID dialysis center, because they had to go to separate ones that we were doing for a while. However, not really. We have one located right in Freeport. There's another one in Hempstead. There's Hicksville. There's tons, but they're usually booked up. So I definitely suggest to do your homework beforehand and make sure they have what they call a chair at the dialysis center to make sure that they come these days and are allotted that amount of time, and that it makes it easier for the nursing home to be able to bring them over to the dialysis for their needed treatment.
Terrific. So Megan, here's a question for you. If my parent is on hospice care but stable, can they get home care too?
They certainly could. They could receive private pay home care services. Hospice is usually covered, as like an end of life, type of service. So if you wanted additional services, you could supplement privately.
Terrific. Okay.
If we're done, I think we've sort of gone over it. Are there any other questions? Okay, so I just wanted to thank Sarah as our moderators, did an amazing job fielding a lot of questions, thanking our panelists, Keith and Megan. And then I wanted to, just before we go, just take a moment to share my screen and go through, just show you quickly the Senior Law Day Collaborative site, which has wonderful resources. You'll see this webinar posted right here. This is where you can register for our next webinar in 2 weeks later today, as well as look at all of our other resources. And I just wanted to take a moment to thank our sponsors. Hopefully you can see we have quite a number of sponsors, and we really appreciate your support.
Can you also just highlight that Ask Us button, because we have a new graphic?
Right here. Right, this is if you have any questions, you can just click on that. So, and we'll get.
And if the question is not relevant to today's program, we'll still connect you with an appropriate professional who is a member of the Senior Law Day Collaborative, who can answer that question for you and get you started on your journey with your family. And if you want to be in touch with Megan or Keith and haven't written down their contact information, you can also reach out to us and we'd be happy to connect you with either or both of them after the program.
Okay. Well, thank you very much for your input, and everyone have a wonderful day. Thanks again to our panelists and moderator.
Thanks, Bruce.